and welcome back to my YouTube channel. Today's video will be on acute myeloid leukemia. So let's get started.
Acute myeloid leukemia. Acute myeloid leukemia or AML is characterized by an overproduction of immature white blood cells called myeloblasts or other type of leukemic blasts of myeloid origin. In AML, genetic mutations occur which stop maturation, increase proliferation, and inhibits apoptosis of myeloblasts. The risk factors for AML are exposure to radiation or chemotherapeutic agents. AML can also evolve from myeloproliferative disorders, myelodysplastic syndrome, and paroxysmal nocturnal hemoglobinuria. It can be associated with aplastic anemia, Down syndrome, Fanconi's anemia, Bloom syndrome, and ataxia telangiectasia, etc. The AML has been classified by the French American British classification from classes M0 to M7. However, the WHO has included a lot of other factors in classifying AML, and here the AML is classified into several types, which are AML with certain genetic abnormalities, AML with myelodysplasia related changes, AML related to previous chemotherapy or radiation, AML which is not otherwise specified. This category includes cases of AML that don't fall into one of the above groups and is similar to the FAB classification, which means it includes FAB M0 to M7 along with acute basophilic leukemia and acute panmyelosis with fibrosis. Other classes by WHO are myeloid sarcoma, myeloid proliferations related to Down syndrome, undifferentiated and biphenotypic acute leukemias. The biphenotypic leukemias are not strictly AML but are leukemias that have both lymphocytic and myeloid features. They are sometimes called mixed phenotype acute leukemia.
According to the FAB classification, morphologically acute myeloid leukemia has been categorized from M0 to M7. In this video, I will be explaining all these M0 to M7 classes in detail. Coming to M0. The M0 is AML with minimal differentiation. In this, there are medium-sized blasts with round nucleus, fine chromatin, and basophilic non-granular cytoplasm. There can be presence of prominent nucleoli, and these blasts resemble blasts of L2 series of ALL. M1 AML is without maturation. In this, maturing cells of the granulocytic lineage constitute less than 10% of the nucleated bone marrow cells. The blasts here are medium-sized blasts with high NC ratio, dispersed chromatin, and one or more prominent nucleoli. The blast may show fine eosinophilic granulation and isolated OR rods in the cytoplasm. M2. It is AML with maturation, which means in this, there is greater than or equal to 10% of maturing cells of granulocytic lineage in the bone marrow. The blasts in this are small to medium sized with high NC ratio and dispersed chromatin with one or more nucleoli, basophilic cytoplasm with primary eosinophilic granules, and isolated OR rods. M3. Acute promyelocytic leukemia. It is of two types, macrogranular and microgranular. In the macrogranular variant, there is abundant eosinophilic granules in the cytoplasm and the nucleus is bilobed or folded. The OR rods can be seen in clumps in these cells, and then these cells are known as faggot cells. The microgranular variant, in this, the bilobed or folded nucleoli with inconspicuous cytoplasmic granules are seen. M4. The M4 is acute myelomonocytic leukemia. In this, along with blasts, there is presence of monocytes and promonocytes in more than 20%, but they are less than 80% of the marrow differential. Both myeloblasts and monoblasts are present. A variant of AML M4 has an increase in eosinophils and it is classified as AML M4E. Coming to M5 class. This is acute monocytic leukemia. in which there is more than 80% cells of monocytic lineage. It is of two types, M5A and M5B. In the M5A subclass, it is basically predominantly monoblasts, more than 80%. And in M5B subclass, there is mixture of monoblasts and promonocytes, but the blast percentage is less than 80%. Monoblast can be distinguished by having a roughly circular nucleus, delicate lacy chromatin, and abundant basophilic cytoplasm. These cells may also have pseudopods. The promonocytes have a more convoluted nucleus, and their cytoplasm may contain metachromatic granules. Coming to the M6 class, it's also known as acute erythroid leukemia. In this, 50% or more of bone marrow nucleated cells should be of erythroid origin. It is divided into two morphological categories, erythroleukemia and pure erythroid leukemia. In erythroleukemia, there is presence of myeloblast and erythroblast. In pure erythroid leukemia, it's mainly the erythroid precursors. M7, also known as acute megakaryoblast leukemia. In this leukemia, there is abundance of megakaryoblast. Usually, they are more than 50%. Morphologically, megakaryoblast are immature mononuclear cells with abundant basophilic cytoplasm containing vacuoles and hyperchromatic and pleomorphic nuclei, with some having cytoplasmic bleps. Coming to the cytochemistry in acute myeloid leukemia. The cytochemical stains which are used are myeloperoxidase, Sudan black B, non-specific esterase, and periodic acid shift stains. In M1, M2, M3, basically peroxidase and Sudan black B positive myeloblasts are seen. Non-specific esterase show positivity in monoblasts and cells of monocytic lineage, and it's positive in category M4 and M5. The periodic acid shift stain stains the erythroblast, and it is positive in M6 series. Coming to the symptoms and signs of acute myeloid leukemia. Because AML developed quickly, people usually report feeling unwell for only a short period of time before they are diagnosed. The patient can present with signs of anemia, which is pallor, persistent tiredness, dizziness, or dyspnea. Also, because of deficiency of neutrophils or normal white cells, there is repeated and frequent infections. Due to very low platelet counts, the patient may experience unexplained bleeding or bruising. Other symptoms are bone pain, lymphadenopathy, swollen gums, chest pain, and hepatosplenomegaly. Occasionally, people have no symptoms at all, and AML is diagnosed during a routine blood test. Coming to the lab diagnosis. The diagnostic workup includes complete blood counts, which show low hemoglobin, low platelets, and high total leukocyte counts usually. The peripherals may show presence of blasts. The bone marrow aspirate is hypercellular with increased number of blasts of myeloid series, and depending on the morphology, it is classified. The cytochemical stains can also be done to distinguish blasts of various lineage. Flow cytometry is done for immunophenotyping as CD13, CD33, CD117, and anti-MPO are immunophenotypic markers of acute myeloid leukemia. Cytogenetic evaluation is also important to detect monosomies or deletion of part or all of chromosomes and trisomy, etc., which are common in AML. Coming to the treatment part of AML. Treatment will depend on the subtype, the genetic makeup of the AML, and overall health and age of the patient. Here also treatment is divided into three categories: induction, consolidation, and maintenance therapy category. The goal of induction is to destroy as many cancer cells as possible in order to achieve a complete remission, and it lasts for 4 to 6 weeks. The most common chemotherapeutic drugs used in induction regimen are cytarabine and anthracycline drugs such as daunorubicin. In consolidation therapy, it is done to lower the number of residual leukemic cells in the body or eliminate them entirely to help prevent any relapse. Additional intensive chemotherapy, allogeneic stem cell transplant are other options. Maintenance therapy delivers a less toxic therapy to prevent relapse after intensive chemotherapy. It is often an extended course of treatment. Not everyone with AML will receive maintenance therapy. It depends on the subtype, consolidation treatment, and risk of relapse. Coming to certain cytogenetic prognostic factors. Translocation between chromosome 8 and 21, inversion of chromosome 16, translocation between chromosome 15 and 17 have good prognosis. And poor prognostic cytogenetic markers are deletion of part of chromosome 5 or 7, inversion of chromosome 3, translocation between chromosome 6 and 9, translocation between chromosome 9 and 22, abnormal chromosome 11, and loss of chromosome or monosome. Inversion of chromosome 3, translocation between chromosome 6 and 9, translocation between chromosome 9 and 22, abnormalities of chromosome 11, and certain monosomies. I have covered all aspects of acute myeloid leukemia in this video. Hope it will help you all. Also, do subscribe to my YouTube channel and share it with your friends if you're liking these videos. Thank you.